know that it is semi-quantitative, the MFI values that we get. The numeric output is semi-quantitative. It's not an absolute value that everybody can quote and titer and all of that. So it's a semi-quantitative output which has to be actually kept in mind that it is variable and it is dependent on various factors, including lab-to-lab variation, lot variation, which loci you are trying to see. If it is DQ or C, it is underrepresented. You may have cryptic epitopes. You may have sharing of antigens or sharing of epitopes. Some modifications in lab may happen. So all of this combined together may have a role on MFI values. And you can see that in this cartoon that ideal is when you have the exact antigen and antibody ratio, but sometimes you may have an antigen excess or an antibody excess. So there may not be a zone of equivalence and that may also render it negative or positive depending upon the output. Of course, there may be a prozone phenomena which may cause the problem, and that's why it may come negative. So this is in fact our paper in which we had a positive virtual cross-match with a negative flow cross-match, and we went on because whenever there's a discrepancy, we do not rely on one test. We need to actually go and look for it, and we found that there were cryptic epitopes. Because it's a synthetic made test, these cryptic epitopes were coming positive, and we had to denature, we had to use the HCl to actually make them redundant, and then we performed the cross-match and it came negative with the virtual cross-match as well. So these kind of problems may occur, and that patient was then taken up for transplant, and it was all very inconsequential. So to recapitulate, in transplant testing, antibody screening, we have quantitative and qualitative. We have a PRA that is there. We have cross-matches that are available like CDC cross-match, flow cross-match, Luminex cross-match, and we have the virtual cross-match. But what does the clinician order? So obviously, whether we go in this direction or that, which test to order, there are so many options what we should do. We are still struggling that we should do CDC or not. CDC is here to stay for a while because I feel it's like an in vitro transplant right now, and no clinician is going to go ahead without doing a CDC. So let us, since it is here, let us master it. So CDC is here. Luminex-based assay, so many tests are available. Which one to employ? Can we take single antigen bead assay as an upfront test and go ahead with the transplant? I don't think so, because single antigen bead assay has its own problem. We have seen many a times when single antigen bead assay may be falsely positive or negative. So you need to have what? You need to have an algorithm. So we were talking about algorithm since morning. There is no single test which can define, which is 100% accurate and sensitive. We need to employ few tests together. The test algorithm should increase the sensitivity and specificity of the test. So what we did is we set out and we found out that, okay, let's go for a multicentric study where 3 main institutes in Delhi NCR got together. Dr. Handu is one of the author for the same. And we actually first, as a pilot study, what we did was we actually made the protocol similar, and the same reagents were used in all the 3 centers, so that we have the same kind of results and we can interpret that with surety. But before that, we did some literature review, and we found that there are many approaches that are available for algorithm. So this is like a Basel approach, and what they do is they do a single antigen bead assay upfront. So everything is virtual cross-match first, and then they go down and see whether it's a no DSA or a DSA, followed by a CDC cross-match. Similarly, Leiden and Minnesota approach, all of them have single antigen bead assay or a virtual cross-match in the hierarchy upfront. So we thought all of these studies, of course, single antigen bead assay, we can also do that, but we all know what are the problems associated with it. One. Secondly, the cost. So all of us are driven with the cost factor, and we know how much we can spend on one patient or one transplant. So we thought, let's do that in our setting, and we thought a separate algorithm is needed where a specific and sensitive cross-match is needed. So this was called the Delhi approach, and we found that individually all these tests, the CDC cross-match, flow cross-match, HAS is antibody screen class 1 and class 2, were having different sensitivity and specificities. But when we combined together, flow cross-match and antibody screen came out to be one test which actually, when combined together, could give us a relative confidence, and the sensitivity and the specificity was actually very increased. So this was called the Delhi approach, and we found that upfront we should do antibody screen and flow cross match, and if any one of them is positive, go for a single antigen bead assay. If both are negative, we don't need to go further with the single antigen bead assay. So that saved us. In most of the patients, you will not have to do a single antigen bead assay or a virtual cross match. So the cost factor is coming. This is the suggested algorithm in this. Upfront do CDC. If it is negative, go for antibody screen. And if you don't have a flow cross match, you can do a Luminex cross match. This is what we do. If it is negative, go ahead with the transplant. If it is positive, do a virtual cross match or a SAP cross match. If it comes positive, obviously you have the desensitization or paired kidney exchange if you are lucky. And if it is negative, go ahead with the transplant. Also, a thing that we at our center feel that if there is a single antibody and if it is greater than 10,000, obviously that is a little riskier and you have to do a elaborate desensitization protocol. Or you have multiple antibodies, but they are more than 5,000. So anything below, it is relatively easy and you can deal with it through the plasma exchanges. So way forward, I feel there is no single test. We should have a cell-based and a bead-based test together, like Dr. Handu also said. CDC is still performed, so might as well do it properly. We get some very good information with CDC. There are other cross-matching techniques that are available, which acts as an adjunct, like HLA antibody screen, very good test. It will give you whether the antibody is present or not present. Flow cross-match, Luminex-based assays are there. SAB assay or virtual cross-match is not the final answer. There are multiple problems and caveats which may happen with SAB assay. However, SAB assay or single antigen bead assay should be performed wherever necessary, and in our algorithm it has a place when either a screen or a flow cross-match is positive. So lab should use testing algorithm rather than relying on just one test or picking one test according to your preference. For our own country, we have the Delhi approach. Of course, we can have a Kerala approach after 1 year. We can have that here. We are starting a new lab. But till then, if you want, you can do that and take our insights. Thank you so much.
Thank you, Dr. Mohit, for explaining all about solid-phase assay. I would like to know about, from your experience, lysate crossmatch. Do you still have lysate crossmatch in your in your algorithm, where this lysate crossmatch is fitting which step?
So, I think when we started the Luminex crossmatch or a lysate-based crossmatch, that was the only crossmatch that we used to do along with CDC. But with time plus after this study, flow crossmatch is the one that we do upfront because of the problems associated with Luminex lysate-based crossmatch, but it is still there. There are some clinicians who fancy it still. I don't know, for some reason, or maybe I don't know, cost so it is there. But now I think we have moved more to the flow crossmatch along with the screen and then single antigen bead assay.
Any question from audience?
As a clinician, from what I understand from your talk is that CDC followed by flow and then single antigen if required. Is that the Delhi approach?
So CDC with screen and flow.
Screen and flow.
Actually antibody screen will give you some amount of confidence that there is some antibody present, and if that antibody is donor specific or not will be actually dealt with in the flow cross match. So if flow comes positive or screen comes positive, obviously single antigen bead assay
should be done, right.
And they are very cost effective also. If you see CDC, anyways we have to do, that's a thing that we cannot do away with as of now. So screen plus flow, it doesn't cost much. Single antigen bead assay, one single antigen bead assay means you have to do class 1, class 2 separately if both are positive, plus you have to do donor HLA typing also. So that whole gamut will cost a lot.
So if you go by the CDC and the flow, if both are negative, you said you can go ahead. Most likely.
CDC, flow and screen also.
And screening. So what will be the approximate cost in the Delhi approach?
Let's not talk about the cost for CDC because CDC anyways we cannot do with it. But screen, and I think sir also said it was around 12,000 or so. One single antigen is around 20 to 25,000, I think. Single antigen class, one class.
Any other question from the audience?
Thank you, Dr. Mohit Chowdhry, for sharing